the disease Amavata and rheumatoid arthritis. So moving to Amavata. Amavata, the disease Amavata, it is not there in Brihathrais. It is mentioned by Madhav Nidana and the books in that series like Yoga Ratnakara, Chakradatta. In Madhav Nidana, it is mentioned after Urustamba Adhyaya. The disease Amavata has been constructed under a wide range of clinical entities in the clinical text. Firstly, the association of Ama with Vata generates a very salient clinical condition termed Samavata, which is characterized by symptoms like Vibandha, Agnisada, Stamba, Andrakuchana, Vedana Shofanistoda, Kramasho Ankhani Pidaya. That means the body part will be affected by pain, swelling, and pricky sensation. Tantra, drowsiness, Saimitya, Gauravam, Snigdhatva, Arochaka, Alasya, Shaitya, Shofa, etc. And the aggravating and relieving factors also explain, that is Snehadi, Vridhimayadi, Surya Mekodhaye, Vardhaye. The condition aggravates on unctus treatment early in the morning and during cloudy seasons. And the pathogenesis and nature of the disease Urustamba simulates that of Amavata. Hence, the condition Amavata is defined in close proximity to that of Urustamba. And in Madhava Nidana, it is explained after the chapter Urustamba. Urustamba is the 24th chapter, and the 25th chapter is Amavata Nidana. And the disease Urustamba, the speciality of Urustamba is it is also a disease caused by Ama and Vata. In Madhavanidana Madhukosha commentary of Amavata, it is said that Urustambe Vayu Same Ityukta. And in Urustamba, the Vayu is associated with Ama. Initiating factor Vata is given importance in Urustamba. And in Urustamba, there it is given Asyam Samprapto Vadasya Pradhanya Muktam. In Urustamba Nidana, mixed Nidanas we can see like Ruksha, Snigdha, Ushna, Shida, etc. And if we are analyzing Nidana told for Amavata, more importance is given to Ama. So we'll move to Nidanas of Amavata. That is विरुद्धाहारचेष्टस्य मन्दाग्नेर्निश्चलस्य च स्निग्धं भुक्तवतो हि अन्नं व्यायामं कुर्वतस्तदा. So individuals who are idle, that is Nishala by nature, and in whom the digestive capacity is low, that is Mandagni, and involved in incompatible foods, that is Viruddhahara, and also activities like Viruddha Cheshta, or like doing exercise immediately after food, or indulge in exercise following the consumption of unctuous food. These are the Nidanas. So in this Nidana, you can like Viruddha Ahara is there, Mandakni, Snigdhanam, Vyayama. In this Nidanas, among these Nidanas, you can find only one odd Nidana is there, that is Vyayama. Vyayama is one of the Lankana, but it can also aggravate Vata. And Vyayama will not aggravate Ama. So from this we can analyze that if a person is doing all these Nidanas like Viruddhahara Sevana along with that if he is doing exercise or any Vekadharana that which aggravate Vata. So the Samprapti of Amavata goes like this. That is Vayuna Prerito hi Ama Sleshmasthanam Pratavati Tena Atyartham Vidakta Asau Dhamani Pratipatyati Vada Pitta Kafair Boyo Dushita So Annacho Rasa Srodamsi abhishantayati jnanavarna adipichila. So the nidanas, the opposite nidanas like Virudahara, Snigdha Anna, and the Mandakni, that which leads to Mandakni, and Nishala, that is, all these nidanas will aggravate, will cause the aggravation of ama in the body, these nidanas. So along with that, we are doing Vyayama also. And then there will be aggravation of Vata also, not only Vyayama, any other things like that which aggravate Vata. So example, Vaigadharana, etc. So this Vata leads motivation of Ama travel towards Shleshmasthana. Vata initiate Ama to travel towards Shleshmasthana, that is Vayuna Prerito hi Ama Shleshmasthanam Pradhavati. So what is Shleshmasthana? Shleshmasthana is Shleshmasthanam Amashaya Sandhyadi. It is given in Madhukosha commentary. So here we can consider Amashaya. Why Amashaya? Because a general rule is there, that is the Dushita dosha circulate from Koshta to Shaka, manifests a disease in Shaka or Koshtanga itself. Based on this basic rule, Shleshmashaya is Amashaya, because here the Dushita dosha travels from Amashaya to Dhamani and settle over Sandhis and produce symptoms. And vitiated Ama, like here, vitiated Ama and Vata, it becomes Vidakta and reaches the Dhamani. What is Vidakta? Vidakta, it is a condition of Ama which is vitiated by Pitta dosha. So almost all properties of Ama is equal to Kapha. So now here you can see now all the three doshas are there, like three Dushita doshas like Vata, Pitta and Kapha, plus Annaja Rasa is also there. And in commentary itself, what is Annaja Rasa means? It is Ama only. That is Amam Annarasam Kejit. It is given in Madhukosha commentary. Amam Annarasam Kejit. So all the three Dushita doshas and Ama or Annarasa, when it enters into srodhas or circulation, it will circulate all over the srodhas, that is three doshas plus Ama. Then the srodhas becomes Srodho Abhishyanta, Jnana Varna, and Adipichila, and start to produce symptoms. This is the Samprapti. And the Lakshanas, and here it is finally it settle down over the Trigasandhi and produce symptoms. And when we'll go to Lakshanas, Lakshanas we can it is of Samanya Lakshanas and Prakopita Lakshanas. And if we see the Samprapti Gadakas, then the dosha is Kapha and Vata associated with Ama, Dosha Rasa, Asti Sandhi, Udbhavasthana Koshta, Sancharasthana Dhamani, Ektasthana Sandhi and Dhamani, Srodhus Rasavaha, Srodho Dushti, Srodho Rota, Rogamarga, Abhindara and Madhyama Rogamarga, and Roga Subhava, Ama and Kapha. Ama Kabam, Atyartha Apakwa Sama Kabha. And Lakshanas, Samanya Lakshanas are Angamartha, Aruchi, Trishna, Alasya, Gaurava, Jwara, Apaka, and Angana Shunata. That is Ankamarta means generalized ill-defined body ache. Aruchi means disinclination to food. Trishna means increased thirst. Alasya lethargy. Gaurava heaviness. Jwara means fever or pyrexia. And Apahaka means indigestion. And Ankhanam shunata edema in the body parts. And next is the Prakupita. Um, Prakupita was the Prakupita Lakshanas. That is the progressed stage of Amavata. As this disease progresses, it becomes very grave in nature. As it advances, it is characterized by Hastapada Shirogulfa Triga Janu Ura Sandishu Saruja Shota. That is the profusely vitiated doshas getting lodged in the joints of upper and lower limbs, heads, ankles, lumbar or sacral joints, that is the trigasandhi, and thighs, and generate painful swellings. And adhyartham ruja vyavita iva vrashika. That means the affected area becomes very painful as if being stung by a scorpion. So in this, you can, if we analyze, you can see more in Samanya Lakshanas, you can see more Amashya predominant symptoms. Like Sandhi symptoms are less, but if you see the Prakupita Lakshanas, the Sandhi involvement is more. Like Sandhi related symptoms, other symptoms are also there, but still Sandhi related symptoms are more. And and the prognosis, the curability, it is based on the degree of dosha association and the extent of its affliction. Ekadoshanugam sadhyam. Amavata, when associated with a single dosha, is curable, and dvitoshacho yapya, that which is associated with two doshas can be maintained by medication. And Sannipatika Sarvadehachara, that which is associated with all the doshas and which features swelling of the whole body is difficult to treat. And next moving to Chikitsa. And based on this, we can, like it is of types Vata, Pitta, Kapha and Sanipatacha. That is for the treatment purpose, that classification. And next is the Chikitsa. So Chikitsa, it is from Chakradatta. And it is like Langanam Svedanam Tiktam Deepanani Kadunicha Virejanam Snehapanam Vastayashama Marude Saindavadya Anuvasya Ksharavasti Prashasyade Amavade Panchakola Siddham Pana Annamishyade Ruksha Sveta Prakartavya Varugai Pudagaistada. So the first statement is Langana. While treating Amavata, the first treatment is to eliminate Ama or prevent the further formation of Ama. For this, Langana is considered as the best treatment procedure. And in this, you have to see the benefits of Langana, that is proper excretion of feces, flatus, and urine, feeling of lightness, and appearance of thirst and appetite, etc. Deepana Kadutikta Aushadis, this type of dietetics drugs helps to promote the functions of Agni. And in this, you can also refer the contraindications for Lankana also. Lankana you can do according to the, for that you have to refer Jwara Chikitsa. And also you can, the Lankana type you can select according to the Bala of the patient. Because the first step is to manage AMA, that is why Lankana. And the properties of, and if we do any treatment to relieve AMA, it will pacify Kapadosha also. And next is the Svetana. In Amavata, Ruksha Sveta was indicated to relieve Amadosha, and it may be performed with the help of Guru Pravarana, that is covering the whole body with thick sheets, or Valuka, that is Valuka Sveta, like with sand, and also Prastara Sveta are beneficial. And some other regimens like Upanaha, Lepa, etc. are also give some sort of relief in Amavata cases. And this order, that is according to, like either it is, you can choose Yadavastam Kramenava. This quotation, this I took from Jwara Chikitsa, because Jwara is the base for all disease, and all the treatment protocols are explained in Jwara itself. So this is applicable for other diseases also. In Ashtanga Hridaya 21st shloka, Jwara Chikitsa, while explaining the treatment procedures, it is explained, Yadhavastam, the last line is ends in Yadhavastam Kramenava, either according to the avastha of the patient or according to the order you can treat. So this you can take to all other diseases also. So that is Svetana. And the Bheshaj, that is Tikta, Dibanani, uh, Kadonicha. So Tikta, you can take, Tiktarasa is having Stambhana property. It is explained in Jwara also. And it is Kaba Pitta Hara. And the Kadurasa is Kafahara. For this, you have to refer that Tatradya. This is based on Tatradya Marudam Grandhi, Sutrasthana. And the Deepana Pachana drugs, that is to correct the acne of the patient. And next is the Virechana. Virechana, Charaka clearly stated that Virechana is the only treatment of diseases which are arising due to Viruddhahara. The reference is Charaka Sutrasthana, 26th chapter, 105 shloka. Here, Amavata manifests due to Viruddhahara, and Virechana helps to eliminate the unwanted toxin from the body. And next is the Snehapana. Snehapana, it should be administered after Amapachana, and it is one of the best remedy for the Vedic dominancy, and along with this, it helps to stimulate the functions of Jataragni. So and next is the Basti treatment. So you can give Kshara Basti. That is a Vaitarna Basti. Chakrapani, it mentioned it under Niruha Vasti, and it can be used in Kaba or Amavasta Avarana conditions. Medogna, it is Medogna, and it improves Agni. Gomutra, Kshara, Tikshna Drivyas are used in this. And the Ksharabasti mentioned in Chakradatta, the Guda, Saindava, Amlika, Shatapushpa, Gomutra is used, and it is indicated in Shula, Vitsanga, Anaha, Mutrakrishna, Krimi, Udavarta, Gulma. The Vaitarna Basti, Guda, Saindava, Taila, Chincha, Gomutra. It is also Shula, Anaha, Amavata, and Vata Kapha disorders. And Eranta Taila Prayoga is also explained in Chakradatta, also it is explained Eranta Taila Prayoga. That is Dashamuli Kashayena Pibedva Nagarambasa Kukshi Pasti Kadishule Tailam Eranta Sambhava. Eranta Taila mixed with Dashamula Kashaya or Shundi Kashaya should be used to alleviate pain in Kukshi, Vasti and Kadi due to Amavata. And for this one quotation is also there like Amavata Gajendrasya Sharira Vanacharina Ekaiva Nihandyashu Eranta Taila Kesari. And other yogas you can use is Rasana. The most commonly used yogas are Rasana Saptakam, that is Rasana Saptaka Kvata, that is the Kvata prepared with Rasana, Guduchi, Aragvata, Devataru, Gokshura, Eranda, and Punarnava. It should be mixed with Shundi Churna, and it should be given when patients suffering from Janga, Uru, Prishta, Trika, and Parsha. That indication is very, very important where we have to give Rasana Saptaka. Janga, Uru, Parshva, Trika, Prishta, Shura. And it should be given along with Nagara Churna. And one more commonly used formulation is Rasana Panchagam. That indication is also very important. The shloka is Rasnam Guduchi Merandam Devataru Mahaushadam Pibe Sarvangike Vade Same Sandhi Asti Majjake. That is very, very important. Vade Same Sandhi Asti Majjake. Where it should be used. And the ingredients are Yasna, Guduji, Eranda, Devataru, and Shundi. And it should be given in Sarvanga Vada and particularly Amavada located in Asti, Sandhi, and Majja. And other formulations like Shatyadi Kvarda and Shatyadi Kalka and also Haridaki Churna and Dashamola Kvada, Shundyadi Kvada, Nagara Churna, and also Panchakola Churna, Amritati Churna, Vaishwanara Churna. All these are indicated in Amavata. In Chakradatta it is explained. And also the commonly used medications like Simhanada Gugulu and many churnas like Shatapushpadya Churna, Hinguadya Churna, Alambushadya Churna, these. And Thailam also like Brahad Saindavadya Thailam, Brahad Simhanada, sorry. And the Gritas which is explained is Nagara Gritam, Amrita Gritam, or Kanchika Shatpala Gritam. All these are explained. While giving Grita, the patient's condition should be, that is very, very important. Already in Snehapana it is explained. It should be administered after Ama Pachana. So, what is that condition? We have to give Grita. In clinical conditions, it should be always when to start Grida is the condition of the patient should be Kafe Mande Vada Pittotere. Only in that stage we can start Grida Prayoga. This reference is also from Jwara Chikitsa only because in that is the condition Acharya has mentioned where to start Grida Prayoga. And this is also applicable for all the diseases. Only in if the patient is in this stage, that is in Kafe Mande Vada Pittotere only, then you can start the Sneha Prayogas. So this is regarding Amavata, and we'll move to disease rheumatoid arthritis. So we'll move to disease rheumatoid arthritis. First, we will see about the disease, and later I will explain about the mm, clinical clinical aspects, like how to deal with joint pain. So arthro means joints and itis means inflammation. Rheumatoid arthritis, rheumatoid comes from rheumatism, which more broadly refers to a musculoskeletal illness. So rheumatoid arthritis is a chronic inflammatory disorder that mostly affects the joints, but can also involve the other systems like the skin and the lungs. And it is an autoimmune disease in which the normal immune response is directed against an individual's own tissue, including the joints, tendons, and bones, resulting in inflammation and destruction of these tissues. And it is characterized by persistent inflammatory synovitis leading to cartilage damage, bone erosions, joint deformity, and disability. So we'll see the anatomy of the joint. A healthy joint typically has two bones covered with articular cartilage at the ends. Articular cartilage is a type of connective tissue that acts like a protective cushion, a lubricated surface for bones to smoothly glide against. One type of joint, like the knee joint, is called a synovial joint. A synovial joint connects two bones with a fibrous joint capsule that is continuous with the periosteum or the outer layer of both bones. The fibrous capsule is lined with a synovial membrane that has cells that produce synovial fluid and remove debris. The synovial fluid helps to lubricate the joint. To help the synovial cells, the synovial membrane also has blood vessels, lymphatics running through it. Together, the synovial membrane and the articular cartilage form the inner lining of the joint space. And rheumatoid arthritis is an autoimmune process that is typically triggered by an interaction between a genetic factor and the environment. For example, a person with a certain gene for an immune protein like human leukocyte antigen or HLD-DR1 and HLD-DR4 might develop rheumatoid arthritis after getting exposed to something in the environment like cigarette smoke or a specific pathogen like a bacteria that lives in the intestines. These environmental factors can cause modification of our own antigens such as IgG antibodies or other proteins like type 2 collagen or vimentin. And this disease, it is commonly in commonly seen in 30 the age group 30 to 60, and it is female to male ratio is 3 is to 1. The pattern of joint involvement could be most common as polyarticular. And the clinical manifestations, it is of articular and extra-articular. In articular, rheumatoid arthritis typically involves um, multiple joints, usually 5 or more symmetrically, meaning the same joint groups on both sides of the body, like both hands or both feet, etc. And commonly affected joints are the small joints like metacarpophalangeal and proximal interphalangeal joints of the hands and the metatarsophalangeal joints of the feet. As the disease worsens, it can start to affect large joints like the shoulders, elbows, knees, and ankles. During flares means that is the worsening of the disease. That is FLAREST. So during flares or sudden worsening of the disease, the affected joints get extremely swollen, warm, red, and painful. Over time, they become stiff, especially in the morning or after being inactive for a prolonged period of time. And these are the relative incidence of joint involvement in RA. The percentage like elbows 50%, shoulders 60% involvement. And thoracolumbar and sacroiliac and distal interphalangeal joints of the hand are not involved. Then instability at cervical spine can lead to impingement of the spinal cord. And the deformities, the people with RA may develop specific deformities, usually of the metacarpophalangeal joints in the hands, such as ulnar deviation of the fingers. In this picture, you can see this is ulnar deviation. And deformities are also common in the interphalangeal joints, such as Botanius or buttonhole deformity. This occurs when the extensor tendon in the back of the finger splits and the head of the proximal phalanges pokes through like a button through a buttonhole, causing flexion of the proximal interphalangeal joint and hyperextension of distal interphalangeal joint. Here you can see flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. Okay. And one more deformity, that is finger deformity, is swan neck deformity. That is opposite to that of Botanius deformity. So in this, there is hyperextension of, see here, hyperextension of proximal interphalangeal joint and flexion of the distal interphalangeal joint. Here, here you can see the proximal. Here the flexion of the proximal interphalangeal joint and the hyperextension of the distal interphalangeal joint. Here you can see the hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint. And in the knee joint, a one-way wall form, that is with fluid from the swollen knee filling the semimembranous bursa. When that happens, the synovial sac can get so swollen that it bulges posteriorly into the popliteal fossa, creating a synovial fluid filled cyst called a Baker or popliteal cyst. Next is the extra-articular manifestations. Extra-articular manifestations include non-specific symptoms of inflammation such as fever, low appetite, malaise, or muscle weakness, and organ-specific manifestations. And these organ-specific manifestations include rheumatoid nodules, that is 30%, rheumatoid nodules or firm bumps of tissue, and this most commonly in the skin around pressure points such as elbows, and more rarely in the lungs and the heart or sclera of the eye. There is also increased risk of atherosclerosis and therefore heart attack or stroke. And there is also anemia interstitial lung fibrosis, and pleural effusions, which can present as progressive shortness of breath. And also Felty's syndrome, that is a Felty's syndrome. It is a triad of rheumatoid arthritis, splenomegaly, and granulocytopenia. And this is rheumatoid nodule. And the diagnosis usually involves confirmatory blood tests like looking for the presence of rheumatoid factor and anti-citrullinated peptide antibody, that is anti-CCP. And rheumatoid factor, that is it is mainly for the prognostic value, and a negative rheumatoid factor may be repeated 4 to 6 monthly for the first 2 years of disease, since some patients may take 18 to 24 months to become seropositive. And the prognostic value, patients with high titer of RF in general tend to have poor prognosis. And the causes of positive test, that is we can see in RA, and also Sjogren's syndrome, and also chronic liver diseases, sarcoidosis, systemic lupus erythematosus. In all these conditions you can see. And the anti-CCP that you can use for both diagnostic and prognostic purpose. And the acute phase reactants, that means acute phase reactants are, they are the inflammatory markers that exhibit significant changes in serum concentration during inflammation. And here you can go for ESR and CRP. And other lab info, acute phase reactants like ESR, CRP, and thrombocytosis, leukocytes, and ANA profile. And the radiographic features like uh, and this imaging studies such as X-ray, it usually reveals decreased bonding of affected joints, soft tissue swelling, narrowing of joint space, and bony erosions. And ultrasound detects early soft tissue lesions, and MRI has greater sensitivity to detect synovitis and marrow changes. And these are the images. And the diagnostic criteria, there is easier diagnostic criteria, and in this a person shall be said to have rheumatoid arthritis if he or she has satisfied 4 of 7 criteria, with criteria 1 to 4 present for at least 6 weeks. So, and the points are morning stiffness, arthritis of 3 or more joints, arthritis of hand joints, symmetric arthritis, rheumatoid nodules, serum rheumatoid factor, radiographic changes. So, in this, at least uh, 4 of 7 criteria, at least 4 points, and with criteria 1 to 4 present at least 6 weeks. And also is here Euler classification criteria. That means European League Against Rheumatism. And in this also you can see some scores and involvements. And this one is joint involvement and the serology and also acute phase reactance and the duration of the symptoms. And a score greater than or equal to 6 out of 10 is needed. Next is the management. And mainly it is focused on the pain management. And different treatment modalities are NSAIDs, steroids, DMARDs, and immunosuppressive therapy, biological therapies, and surgery. So, non-steroidal anti-inflammatory drugs or NSAIDs or COX-6, that is COX-6 is also known as COX-2 inhibitors. They are a type of non-steroidal anti-inflammatory drugs. And this NSAIDs, it is to reduce pain and swelling, and they do not alter course of the disease, and chronic use should be minimized. The most common side effect is related to GI tract. And next is the corticosteroids. Corticosteroids also you can use, like indications for systemic steroids are for treatment of rheumatoid flares. Flares means already I said is a worsening of the disease. And for extra-articular rheumatoid arthritis like rheumatoid vasculitis and interstitial lung disease, etc. And next is the DMARDs, that is disease modifying anti-rheumatic agents. The long-term management of rheumatoid arthritis is use of disease-modifying anti-rheumatic medications like methotrexate, hydroxychloroquine, sulfasalazine, and which can help to suppress the inflammation. And this DMARD, that is disease-modifying anti-rheumatic drugs, they are a group of medications commonly used in people with RA. And they act by altering the underlying disease rather than treating symptoms. They are not painkillers, but they will reduce pain, swelling, and stiffness over a period of weeks or months by slowing down the disease and its effects on the joints. And it is of two types, the conventional DMARDs and biological therapies. In conventional, which I already explained, that is methotrexate, sulfasalazine, and hydroxychloroquine. These are the conventional type. And when to use this DMARDs? It is indicated in all patients with RA and who continue to have active disease even after 3 months of NSAID. And how to select? There are no strict guidelines, but methotrexate has rapid onset of action than other DMRT. And methotrexate is a drug of choice. And the next one is the biologics in RA. So it's conventional DMRDs and biological therapies. In that, biologics such as you can see here, abatacept, it was abatacept, and this work by suppressing the activity of T cells. And others such as rituximab, it acts by suppress the B cells. And there are also biologics like adalimumab, etanercept, and also infliximab that blocks various chemokines like tumor necrosis factor. And anakinra, it blocks interleukin 1. And tocilizumab, it blocks interleukin 6. Treatment of acute flares can be done with anti-inflammatory medications like NSAIDs as well as short-term use of glucocorticoids. And how to monitor treatment in RA, this I will explain in case. And in surgical approaches, synovectomy, it is not usually recommended for patients, but like uh, one exception is the synovectomy of the wrist, which is recommended in intense if the patient is having intense synovitis, if it is persistent, then and medical treatment over 6 to 12 months. Persistent synovitis, including the dorsal compartment of the wrist, can lead to extensive tendon sheath rupture, resulting in severe disability of the hand function. And this surgery, this won't cure the disease, but for the pain management, they can use. But this is not a permanent solution. Only pain will reduce, but other complications will be there. So we'll go to the joint issue. We already discussed about the rheumatoid arthritis disease. The main feature is, as I said, the joint pain. So in our clinics, when a patient complains of joint pain, if he comes, what are the things we have to do? So first, find out whether it is due to articular involvement or extra articular involvement. And if the pain is articular, then the next step is to find out the nature of pathologic process, whether it is inflammatory or non-inflammatory. So we have to know what is the difference between inflammatory and non-inflammatory arthritis. So the symptoms in morning stiffness, in inflammatory it is about more than 1 hour, and non-inflammatory focal and brief. And the systemic symptoms like fever, fatigue, weight loss, that will be present in inflammatory arthritis, and it will be absent in non-inflammatory. And the peak period of discomfort, that is after prolonged inactivity, and in non-inflammatory it is after prolonged use. And the symmetry in inflammatory, the symmetry is common. Symmetry of joints you can see, and non-inflammatory it is occasional. And the signs like swelling, warmth, and erythema will be positive in inflammatory, and pain without erythema and warmth you can see in non-inflammatory arthritis. So this is very important for your clinical aspects. And causes also, like inflammatory causes, like the rheumatoid arthritis, you can in that infection is there immunologic reactive, in that rheumatoid arthritis comes under immunology. And if it is non-inflammatory cause, you have to analyze what is the cause, like trauma or degenerative or those neoplastic, uh, those causes. And the next step, we and the next step is to find out the pattern of involvement, like whether it is monoarticular, oligoarticular, and polyarticular. Monoarticular means one joint, or oligo means 2 to 4 joints, and the polyarticular means more than 5 joints. Usually in rheumatoid arthritis, you can see the polyarticular, and again in that you can classify categorized into asymmetry and symmetry. Rheumatoid arthritis, you can see symmetric polyarticular involvement. And if it is polyarticular, then again find out whether it is due to like following will tell, like it is due to symmetrical, asymmetrical, additive, or flitting. The symmetrical, this will comes under, RA will comes under inflammatory, And the next is already we discussed in inflammatory joint pain and non-inflammatory arthritis. So same, the features of inflammatory joint pain and non-inflammatory joint pain. That is the features of inflammatory joint pain. The rest pain, that is worse after pain, worse after rest, and improved by movement. That is present in inflammatory joint pain, and rheumatoid arthritis is an inflammatory condition. And so you can see this inflammatory pain in rheumatoid arthritis. And the systemic symptoms like fatigue, weight loss, and fever are present. It is also seen in rheumatoid arthritis. The signs of inflammation like pain, redness, warmth, and swelling are present. And morning stiffness persists for more than 1 hour. And morning stiffness of inflammatory disease that will improves with activity. So in rheumatoid arthritis, you can see all this, and you have to know what are the features of non-inflammatory joint pain also. In non-inflammatory joint pain, like in osteoarthritis and all, like the pain without swelling or warmth of the joint, and the absent systemic or inflammatory features, minimal or absent morning stiffness, and usage pain, that is pain worse on use and relieved by rest. But in inflammatory joint pain, that is worse after rest. That is the difference, and improved by movement. But in non-inflammatory, it is pain worse on use and relieved by rest. And pain mostly at night, and it is poorly related to movement. And the in non-inflammatory causes are osteoarthritis, etc., uh, or osteoarthritis like an avascular necrosis, all those conditions. And what is the mode of inquiry, like what we will ask to patients? So age of onset you have to ask, because the rheumatoid arthritis and it is most commonly in middle age. Already we said it is in the third to sixth decade, so the middle age. And sex, it is also important because females are most prone to rheumatoid arthritis. And also the duration and onset, because rheumatoid arthritis, it will be chronic, that is more than 6 weeks. And what is the next is the what is the pattern of involvement, that is number of joints involvement. Already we said that it is rheumatoid arthritis is polyarticular, that means more than 5 joints are involved. So more than 5 joints are involved. Then we have to know which joints are involved. So in RA, usually smaller joints are involved more than the larger joints. Usually metacarpophalangeal joints, and also the axial skeleton. All these are involved. And also we have to find it is symmetrical or asymmetrical. And in rheumatoid arthritis, it will be symmetrical involvement. Symmetrical means both hands, right and left, for example, right and left hands, both right and left shoulder joint, or right and left elbow joint, right and left knee joints. That is bilateral knee joints are affected. That is symmetry. And also look for deformity, because it suspect rheumatoid arthritis. And also the signs of inflammation, like redness, pain, swelling, warmth, if it is present or not. And if all or some features are present, it suggests inflammatory cause. And if it is more than 6 weeks, it is chronic cause. And also you have to ask what are the aggravating and relieving factors. Like pain relieved by rest means it will be mechanical pain that is by more on use, that is that pain relieved by rest, that is mechanical pain. And if the pain relieved by activity means it is an inflammatory pain and it is more at rest, that is seen in rheumatoid arthritis. And also associated any extra articular symptoms, if it is there, that also you have to see. And also you have to ask for any family history of rheumatoid arthritis. So these are the mode of inquiry. uh, so if your patient comes to you with a joint pain, you have to assess all these things. So this is about rheumatoid arthritis. And to summarize this, rheumatoid arthritis is a systemic inflammatory disorder of autoimmune origin that is primarily characterized by progressive symmetric joint destruction, especially in the wrist and fingers, but may also affect other joints and many organs such as skin, heart, blood vessels, and lungs. And it's marked by elevated rheumatoid factor and anticyclic citrullinated peptide antibodies, that is anti-CCP. So this is about rheumatoid arthritis. Thank you. Any queries?